I want to be invited back to the next great debate, so I'm going to be very gentle on Dr. Govindan and make his job easy. Now, this is sort of the case. This is 2 cases from my clinic. 68-year-old woman referred with a lung mass, has liver lesions, MRI shows no brain metastasis. Patient undergoes a biopsy of the liver, small cell lung cancer. Diagnosis is extensive stage small cell lung cancer. Patient is a good chemotherapy candidate by all criteria. The second case is a 56-year-old gentleman who presents with hemoptysis, CT scan performed. This reveals bilateral pulmonary nodule, mediastinal disease. A PET scan reveals bone disease. Biopsy reveals squamous histology. He is stage 4 non-small cell lung cancer squamous histology, and also a good chemotherapy candidate. So let's take a look at the therapies for case 1. Small cell represents about 15% of small lung cancer. This is from Dr. Govindan's work. In 1987, when I graduated high school, the standard was platinum etoposide. In 2013, still platinum etoposide. So the novel agents haven't really moved the curve in small cell or changed any of the therapy at all. Case 2 is squamous histology, which is about 20 or 30% of the cases of non-small cell lung cancer. So it's a significant patient population. In 2003, when they did the ASCO guidelines, the standard was a platinum doublet. In 2013, it is also a platinum doublet. What I think this gets to is that the novel agents have helped a very narrow window of the patients that we see every day in clinic. It's really been focused on this slide, which I've presented 15 times. I think all the faculty have. We love this slide. Importantly, I think it's time that we really look at this slide. All the patients had adenocarcinoma. This was performed at 14 referral centers. The patients most likely were younger. There's a higher proportion of never or light smokers in this. And I think it's important when we look at this, the 2 actionable genes outside of clinical trial are EGFR and ALK. Here it's 17% and 7%. I hazard to say that the prevalence in your clinic is lower. I think when we go to clinic on Monday, this is what our lung cancer patient population is going to look like. About 40% adenocarcinoma, 20% squamous. Then we have this problematic other. It's either adenosquamous, sarcomoid, which people have brought up, large cell carcinoma. And I don't think we really know what to do with these people. I think some of those histologies probably have a low rate of EGFR, ALK mutations. And the majority of these people are going to get chemotherapy, which is a platinum doublet. Now, the big progress has been touted as this EGFR tyrosine kinase inhibitors. And you've seen this slide in a number of iterations, so I won't belabor the data. I think I'd concede a consistent improvement in response rate, a consistent improvement in progression-free survival, and a consistent lack of improvement in overall survival. And I think the issue here is that it doesn't really matter if you get it first line or second line, as long as you get it. I think the other issue that we got to take a look at is all the patients enrolled on this trial were either Asians with adenocarcinoma and never light smokers, or adenocarcinomas and never light smokers were the majority of the people on the Eurotrack trial. If we go back to 2005 and the EGFR mutation was never discovered, clinically we would have all treated these patients in the second line setting with an EGFR TKI based on the data from promising response rates, and they would have had a similar benefit. Thus, when we look at this, the same number of patients are getting the EGFR tyrosine kinase therapy as in 2005. It's just now that we feel better about using it in the first line setting. The survival benefit remains the same throughout. Now, we've done a number of trials of EGFR tyrosine kinase inhibitors versus platinum therapy, and now we have a new kid on the block. Congratulations to the approval yesterday. Well, let's take a look at this trial in particular, because it's going to be a novel agent that's out there. They use afatinib 40 milligrams daily compared to cisplatin pemetrexed, which would probably be the preferred platinum combination in this patient population. And very similar to the other trials, they showed an improvement in response rate, improvement in progression-free survival, and the overall survival is pending. Now, I think the question that really comes up with this agent compared to the previous agents is what is the toxicity? And I've highlighted some of the toxicities of this agent. I'd like to focus your attention on the grade 3 and 4 toxicities that are here. It looks like we have about a 14% rate of grade 3 diarrhea. That's significant inconvenience to the person who has it. There's significant rash and acne, the high rate of mucositis, which is very painful for the patient. And about 10% of patients will get paronychia. And this is a very problematic and symptomatic toxicity. So these toxicities are not trivial. When we compare the erlotinib versus the afatinib toxicity, which I think many of us are sort of running through in our mind, I've put in the erlotinib toxicities there. The erlotinib, they presented the grade 1 and 2 toxicities, and the grade 3 are in parentheses. The afatinib was presented in a slightly different manner. Those are all grades with a grade 3 in toxicity. But it does appear that there's more toxicity with afatinib, and in addition, more grade 3 toxicity. So the additional efficacy of afatinib compared to erlotinib is really unclear because we don't have a prospective trial. I would argue that the additional toxicity is unambiguous. The next question, is which Dr. Govindan alluded to, is the ELK trial. This has garnered a lot of press, and it's very popular, even if it is a small segment of 2 to 4% of our patients. They did this trial that took crizotinib compared to pemetrexed or docetaxel. The primary endpoint was progression-free survival. You were allowed to cross over to crizotinib in the second-line setting. And here are the results. If we look at independent radiological review, on the chemotherapy arm, it was about 3 months, which is very similar to previous second-line trials. On the crizotinib arm, it was 7.7 months. So this breakthrough medication is just delaying disease progression by 3.5 months. No difference in overall survival. Admittedly, the crossover problem does arise. But I think that this raises question is, what is the magnitude of benefit of this novel agent if it's only 3.5 months improvement of progression-free survival? I would like to sort of focus on some of the issues here. For patients with small cell and non-small cell squamous agent, there's no novel agent, and there's none that are readily available. I think when we look at the epidemiology, only a small minority of patients will have EGFR mutation or ALK rearrangement. For those with an EGFR mutation, the progression-free survival observed on these trials is around 10 to 12 months, and the median overall survival of 20 to 30 months. I also think that there's a huge discrepancy when you come in with your EGFR mutation test positive, talk about erlotinib, tell how great it is, then you tell that 45-year-old or 55-year-old woman, hey, you know, this is going to work for about a year. They're crestfallen. That's not very good to them. It's not good in the patient's mind that it's only delaying growth for a year. And the prospect of a 1 or 2 year survival is still very, or 2 or 3 years, is very poor. And I think that we need to keep these things in mind. I don't see afatinib as an additional therapy changing the PFS and overall survival in this patient population. For the ALK positive patients, I think the median progression-free survival is about 8 months, and the median overall survival has generally been about 20 months. Still very modest and much farther behind other solid tumors that we treat, that you all treat, I don't treat, every day. Thus, the vast majority of our patients are still going to get some iteration of a platinum doublet, which is very similar to where we were in the 1990s.
Thank you.